This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com. Today's episode of Red Hot Healthcare is sponsored by Walk the Ridge. Incivility between those of different opinions and views is skyrocketing. It's causing harm to relationships as well as results in corporate culture. Walk the Ridge is a movement that's free to join, and it stresses that people practice tips and strategies in better listening and more civility. Join for free and download our free guides for individuals and businesses at walktheridge.org. That's walktheridge.org. Walk the Ridge, promoting greater civility in our society. Jonthan Wiik serves as principal at TransUnion in the Healthcare Solutions Division. He has over 20 years' experience in healthcare and has worked in both the acute care and insurance setting. He's spoken at several national and state events and has developed several nationally recognized programs in point-of-service collections, financial clearance, and sharing best practices in hospital operations. Jonthan, we are broadcasting live from HIMSS, and it is a privilege and a pleasure to have you on Red Hot Healthcare. Thanks for making the time.
Thank you, Steve, for having me today.
Okay, Jonthan, let's just jump right on in. No one is really surprised at the rising costs in healthcare. I mean, you'd have to basically be hiding under a rock to see in the last 10 years, deductibles have skyrocketed, co-payments, co-insurance, and of course, the medical debt has gone up as well. But I think people are going to be very surprised at just how high they've become. I think there's a disconnect into the real-world plight of what's going on with the average American in healthcare. So what I'd like to do is have you give the audience an idea of the growing numbers and the pressure placed on today's patients.
So we did a study at TransUnion to look at the deductibles over the last few years and trended that out based off some estimates we ran. And I agree with you. I think the market does realize that costs are escalating, and that's happened over the last decade or so, but the amount is what's really alarming. I think Q4 of last year, 2016, we had an average deductible or out-of-pocket cost of $1,630. That's up to $1,813 now. So that's almost $2,000 for a patient. The Federal Reserve did a study in 2016 that said that most people only have about $400 to cover a hypothetical expense. Most people aren't writing checks just out of the blue or putting their credit card down for a $1,400 expense. So I think that's where the disconnect lives, is that healthcare costs are high, but with that, the out-of-pocket coverage hasn't necessarily trended with that. The Kaiser Family Foundation study has performed a study that shows how much deductibles have outpaced wages and inflation. Deductibles are like 230%. Wages have been relatively flat in the single digits, about 5 or 6% increases, maybe 11. And inflation, as we know, is running around 3 clicks a year, 3%, 3%, 4%. So you see this graph, if you can visualize that in your head, of this Switzerland ski slope of deductibles, and then down below there are kind of the planes of your wages and inflation. And so there's a huge disconnect between what the out-of-pocket is and what we're getting paid as a society and what's actually being covered. So it's been very challenging.
Yeah, I think one of the things that I find very interesting, in particular when you talk to the average person on the street, white collar or blue collar worker, and they'll say, oh yeah, my healthcare, my company pays for that. And they said that 15 years ago. They said that 20 years ago. But the very interesting thing about that is that they were always paying for it. And, a lot of people were just led to believe that it really wasn't their money. And of course, it always was their money. The costs were always being passed down. You wrote a great book entitled Healthcare Revolution: The Patient is the New Payer. I couldn't agree with you more. I would also say, too, the patient is the new customer, where I feel like in fee-for-service, and you'll probably agree with this, that for many years, it was the payer that was really the customer of the healthcare provider in the hospitals. On this book, The Patient is a New Payer, I'd like you to take us through the highlights, if you could, please, Jonthan, just in terms of, top-level issues that you discuss and maybe just some of the broader conclusions that you're drawing out.
Yeah, the book really genesised from my career. I started pushing wheelchairs around a hospital, believe it or not, and moved into an operational role in an imaging department. X-ray or radiology is what it used to be called, and we started being asked to collect money from patients before other areas in the hospital. I think that was for two reasons. One, our episodes of care were much more predictable and singular in nature. So we, would see someone for an MRI or a CT scan or an ultrasound, and that might be the last time we see them for another 4 or 5 months. And so that was the only opportunity we would have to collect from them. Secondarily, those were some of the areas that insurance companies started having a lot of cost sharing with, co-insurance, deductibles, things like that. So that really started kind of my journey in patient finance, believe it or not, is trying to administer something that was collaborative and compassionate to a patient who had never paid us before. And as I watched those amounts get higher and higher, and as my career evolved into being a chief revenue officer at a hospital where I had the billing components and the utilization review elements, as well as the financial counseling and charity, even the chaplains at one point, we prayed about our bills. But I mean, having all of those things, we started doing, WebExes and things on that. And we really, started talking like we should put some of this down into a book. And that's what we did. An overview of the book, it is in thirds, where we've went, where we are, and where we're going. A lot of people don't know the history of healthcare. Of all the compliments I get from people that have read the book, that's the most prominent, is I had no idea that, healthcare started from the railroad industries with inpatient care, and we didn't have insurance, and it was before Medicare, and before people just paid doctors, and they came over and they, traded goats and chickens and things like that. And there was just physicians and there weren't hospitals. And then hospitals became a ward where people got better that was ran by ministries or nurses. And Blue Cross Blue Shield and the Baylor plan is where insurance started way back when. And that was something that the employers never funded. But then World War II happened, and in an inflationary tax rule that was very interesting to prevent what had happened in Germany with their economy, came into place to say you couldn't give people a raise. And so instead of giving people a raise, they gave them health benefits. And here we are. And to your point that you made earlier, you were paying for them either indirectly or directly. You didn't get that raise back in 1950, whatever it was. But your employer gave you that incremental increase. And now I would argue they're on the hook to continue to do it. It's very interesting, kind of this pattern that we've came into to where most employers are shelling out 30 to 50% of the premium costs for their employer group, throwing their hands up going, I can't afford this liability on my books anymore. The people are getting, they live longer, but I would argue that we're not living healthier. I think we're getting sicker as a society, both with choices that we have and just other things. And so the incremental cost that has been put on the employer, the system itself, is starting to trickle back in the last, I'd say, decade to patients. And that's why you're seeing this revolution happen now as we get into that part of the book. It's patients are like, whoa, $4,000 deductible. I'm not paying that. Well, your employer has been paying a $4,000 deductible for the last 10 to 20 years. You just didn't see it. It was indirect on the bill, and you're like, oh, I got insurance. It's fine. The underserved and needy are also an area that I talk about in the book in terms of just the government having to fund that. And the book talks about, other countries that have single payer systems or universal health coverage, like the UK or Canada or Germany or Switzerland. There's pros and cons of those. You hear that a lot in our news today about whether we think that's something in our country's future. And the last part of the book talks about that. What would that look like? If we had that, what concessions would we have to make as an American society that wants my healthcare right now, right away, my way? Because those countries don't deliver healthcare that way. It's actually rationed, and you have choices, and there's weights. The quality, one would argue, may or may not be at the caliber that is the United States. There certainly isn't as much innovation. And so those types of things become challenging as the patient becomes a consumer, as they navigate the system.
So in your book, one of the quotes that you pulled out that I liked was, given the increased payment responsibility, being able to determine a patient's ability to pay is increasingly important for hospitals. I'd like to know a little bit about what TransUnion has done for hospitals in the respect of this proactive identification, and maybe what have been some of the positive outcomes that you're seeing, as well as maybe even the ROI.
Yeah, thanks, Steve. I think when a patient comes in as a consumer to a hospital, that payment's going to end up in one of three buckets. It's going to end up as bad debt, as charity, or a payment, right? And so what TransUnion Healthcare is trying to do is differentiate and provide insights as to the risk of the patient going into those buckets or the benefit. And so we do develop tools to help hospitals have predictive analytics or associate risk with a payment. Examples of that, charity care is probably a great one. So 501R is an interesting rule that the IRS has that came out of the Affordable Care Act. It went into effect last year. That's a rule that says that you are not able to put patients into collections without first screening them for charity or documenting that they didn't get charity. A lot of people don't know about that rule, but it's a rule as a not-for-profit that hospitals have to follow. So we help hospitals determine income and household size based off some data sets that we have to determine whether they're presumptively eligible or eligible for charity. Because otherwise it's the patient saying, yeah, I don't have any money, and there's no qualification to that. Sometimes our tools refer to as a lie detector, if you will, but it's good. It's substantiating data to what the patient's saying, or if the patient's not saying anything, it's filling a void with data sets. A lot of patients that don't have insurance may or may not have a job, typically seek out the emergency room as their care, go to different emergency rooms. And so that demographic data and socioeconomic data isn't there. TransUnion has that data. We can take that information and provide it back to you to say, Mr. Wiik, makes $45,000 a year and is at 280% of the federal poverty level. He's eligible for your hospital's charity program. You should sign him up next time he comes in or before he leaves. Those are types of things that we do. In the payment bucket, we have propensity to pay analytics, and that really is differentiating ability to pay versus their willingness to pay. That ability versus willingness is a big thing. Do I have patients that can pay me, but they need help? Like we talked about that $1,400 bill earlier. That's a large burden to most households today. And so how is that $1,400 going to get paid for? I will tell you, at my hospital, if I asked a patient for $1,400, it was a rare circumstance that was paid right then and there. I typically got the just bill me response, which then is the traditional way of billing over time, which is expensive, inefficient, impersonal, and I would argue very generic, right? And that's part of the problem with healthcare finance right now is these bills come in the mail. You don't understand them. There's multiples of them. They don't rank high. Most patients rank a consumer medical bill at number 7. That's a McKinsey study that we can get for you if you like. That's ranked below your mortgage, your cell phone, your car payment, your premiums, your healthcare premiums. But the actual payment of your healthcare is number 7 out of all the bills that you have in your household. We all have one at home. I have some numbers for you too. 1 in 4 patients have a bill they need help paying. 1 in 5 have a bill at home of some sort that they will pay over time, and 1 in 10 have a bill they will never ever pay. And so those are staggering statistics that come from a study. And so what we're trying to do is push to the edges, if you will, with our data and risk analytics at TransUnion. So what's this patient's likelihood to pay? We leverage many data sources for that. Credit is king. Anything else that is the magnitude of cost that healthcare is financed. Your lease, your car payments, your mortgage, your 82-inch television set. Any of those things all involve a loan of some sort, typically, and a credit score. Healthcare is interesting that they haven't adopted that technology yet, or that operations protocol. I think it's for a few reasons. One, I think healthcare costs have outpaced financing and funding, and I think that hospitals are playing a little bit of catch up now. I think it's reputational. Why are you running my credit? You're a hospital. You're supposed to treat me regardless of my ability to pay. I'm entitled to this healthcare. Those types of things happen, and that's a dynamic that hospitals and providers have to navigate. We provide non-credit alternative data sets as well, based off Census Bureau data and proprietary data that's at TransUnion to estimate family size and income. But all of that data is kind of leveraged to understand, okay, what types of patients do I have? Do I have one that's going to pay me? Do I have one that needs help paying over time? Or do I have one that has no ability to pay that I should really put into my charity association? But that's what TransUnion is doing to help in that area.
So, Jonthan, while non-payment from patients is a huge concern, attracting patients into your provider facility, it's sometimes even tougher. And a survey from last year, I think it was Remit Data, found that nearly 50% of revenue cycle management vendors and companies said acquiring new patients was a top challenge. So here we are, right? We're in a situation where health systems and providers are looking to get new patients, but you've got care, you've got drugs, and care coverage is skyrocketing in costs. And for many people, it's just unaffordable. Maybe you can give us some ideas on the solution that's going to work here. How are we going to look moving forward at both achieving growth in terms of patient acquisition, while at the same time trying to alleviate all the pressure that's going on with the unaffordability and with the growing debt?
I was attending a session earlier today at the Revenue Cycle Summit, And one of the stats that just I kind of sat back in my chair, there's not too many that do that these days, but this one did. They said that 75% of healthcare decisions will be made by a millennial by 2025. Millennials do not pay their bills via paper at all, are pretty finicky or thrifty in terms of the healthcare that they're going to acquire. They're used to doing things on their phone, cashing, direct withdrawal, looking up where they're going to eat tonight, going to Open Table, getting an Uber, checking their bank account, transferring funds, booking their next travel, ordering their groceries. All that stuff happens in a mobile type experience. Very little of that happens in healthcare. It's starting to. I'm excited about that. I think TransUnion's looking at developing portals and things as well to help patients be engaged. When I hear this question about growth or retaining your patients, what we called it in the industry was patient leakage. As weird as that sounds, but volume leakage, or having patients leave your network for another one, or not come back to yours. That was more about the clinical side of it. That patient's part of your family, and you want them there, and you want to be able to deliver that care. Financially, that can disrupt that. The first and last impression a patient has in a healthcare setting is the bill. Hi, Mr. or Dr. Ambrose, welcome to our facility today. Thanks for choosing us. I need your ID and insurance card or a form of payment, right? And then an envelope will come in the mail, about 3 weeks later that says you were here and here's your bill. First and last impression. So that first and last impression needs to empower the patient to want to come back, right? So I'm seeing lots of things like that. Hey, we saw that you had a knee surgery. Have you picked a gym out in town? I see that you pay your bills typically online through Chase. You know that our hospital has auto withdrawal from your checking account for that. We can swipe a credit card on your first visit, and then that's your account, and it all hits that. And before it goes there, we'll let you know, and you could review the charges. I hear this term a lot now, and I love it. Frictionless payment. I think it's great. I think it's a silky, way to where you're paying for everything else, like your airlines, your groceries, your rental car, your mortgage. The millennials are already there. And I think healthcare knows that. They're trying to create this patient experience. I would like to have that word patient financial experience in there as well, to where they've got this clinical and financial plan kind of commingled together. They shouldn't disrupt each other necessarily, but I think if you're going to grow your patient base, you're going to have to be better than others at delivering quality care at a low cost that's easy to pay and access. Because if it's hard to pay and access, there's going to be folks out there that'll make that part easy and more frictionless.
I do want to ask you, because we did talk a little bit about life sciences and pharma. I know that the medication adherence market right now is estimated to be a $300 billion a year problem in the United States alone. And I'd like to know if TransUnion has thought about, or has it reached out to the life sciences or pharma side per their issues with affordability, and perhaps even helping to keep people loyal with staying on medications that they may stop taking solely because of affordability.
That's a great question again. So I think there's a few things with that. So TransUnion's, at its core, a data company, a very good one, I might add. We have 80,000 databases that have data on, financial information, banking information, lending information, public record, DMV, all kinds of things like that. And what TransUnion looks at is correlates. That's what I'd like to call it. And I think what conversations that we're having now that are really interesting to me is ones that center around like social determinants of health. And so, what are some correlates that drive behaviors? Is there a correlation between the number of pharmacies next to a certain zip code or not? Those are things that TransUnion has data on. We don't necessarily know whether the prescriptions are going there. The providers and the payers have that, but I think it's that marriage of data that's going to be really exciting for the future. We have data about what kind of car someone owns, or whether it's their third car, or whether they make their payments on time, or where they live, what their phone number is, whether they have a cell phone, how many kids they have, how old they are. And I think there are links in that if you start digging into that data set to say, hey, a 45-year-old gentleman that lives in zip code 10678 that drives a Honda will fill his script, the first 6 times, but not the last 10. And that gets really exciting, right, to the pharma company, because then they need to develop a drug that can be given a dose in 6 doses instead of 16. So things like that become very exciting to TransUnion. We're starting to talk about, how can our data sets leverage behavior like that and do it. We're not in the business of delivering care, but we are in the business of delivering risk, I like to say. And I think that's important. And, can we show correlates and different stratifications of risk to the market to where they can understand that from a business perspective? Because that's what's missing in healthcare, I think. I think it's delivery. I think it's very, it's evidence-based, but it's very traditional and it's very generic. It's got an evolution with patients. There's a protocol that's followed, and then if the patient deviates from that protocol, there has to be some interaction that happens, and you can get wrapped around the axle very easily in healthcare if one or two things happen, and you can go down a path that the physician and the provider never intended. What's the risk of that happening is what we're looking at and what we're trying to create.
Jonthan Wiik, Principal at TransUnion in the Healthcare Solutions Division. Jonthan, I want to thank you so much for making the time to come with us here live at HIMSS for Red Hot Healthcare. Just a tremendous back and forth. I know the audience really appreciates all that you were able to glean on today, as do I, and I'm looking forward to hearing about great things for you personally and also for TransUnion moving forward.
Thanks, Steve. It was a pleasure, and look forward to seeing all of you at HIMSS.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.